Good evening, everyone, and thank you for joining tonight's clinical webinar, Tips for Improving Your Contact Lens Fits. Before we get started, I'd like to point out that you have a text box on the right side of your screen for asking questions, and I would encourage you to ask questions during the presentation, and we'll have a short Q&A session following the lecture. Our speaker tonight is Dr. Stephanie Ramdass. Dr. Ramdass is a clinical research fellow at Michigan College of Optometry's Vision Research Institute in Big Rapids, Michigan. Her research interests include myopia control, presbyopic lens designs, and the application of scleral lenses. After hearing one of Dr. Ramdass's lectures on lens fitting at the Global Specialty Lens Symposium, we were compelled to invite her to speak during one of our webcasts to share her insights on the subject, and we're thrilled that she accepted our invitation. So without further delay, on behalf of OCULUS, I'd like to welcome Dr. Stephanie Ramdass.
Hello, everybody. Thank you for joining in today's feature webinar. Thank you, Chris, for that introduction. I also want to thank Oculus for this opportunity to share a little bit about some of the applications that we have found the keratograph useful for in our optometric setting, specifically here at the Michigan College of Optometry. I want to take a look in relation to contact lens fitting per se, and hopefully through listening to the webinar, maybe you can pick up on a few tips to improve your fits. Now, I am currently the Contact Lens Research Fellow at the Vision Research Institute at the Michigan College of Optometry. Specifically, the Vision Research Institute, or the VRI, we carry out a variety of different studies and projects with some of the industry leaders you see on your screen there. Ultimately, we are interested in utilizing equipment that can supplement the eye exam. We want to see how much they can be used for what their claims are, but as well, can we maximize what their applications are based on what we do. So when I'm actually talking about contact lenses, if I refer back to my title, it's, tips for improving your contact lens fits. That would imply that there is, perfection's not attained yet, that we can make an adjustment in how we are fitting our patients. I don't think that it should be a concept that we are perfecting. There's always something new to learn. And perfection is not an attainable goal. I mean, if we look at some of the facts, we can all probably attest to the fact that we have had that patient that's in our chair. They have symptoms of dryness, they're irritated with their contact lenses, they may feel fatigued at a certain point, they have complaints of glare and halo. This is not new, and it can be frustrating for us as practitioners, and we want to help our patients out. Now, the Tear Film and Ocular Surface Society, TFOS actually, they provided us with the dry eye workshop, the DEWS report, and the Meibomian gland workshop, dysfunction there workshop reports. And they've also, out in 2013, provided us with the publication specifically looking at contact lens discomfort. And some of their reportings, they gave us an official definition of contact lens discomfort. So it is a condition. It is a condition that's affecting many people. But it also states that, there could be the lens itself causing this dissatisfaction and this discomfort, or it is the environment. It's a complement of both. We as practitioners may be able to control more of one aspect than we can of the other, and knowing where we can make those adjustments is really how we can control the exam a little bit better. Now, this study, it's a wide range. It reports that there's anywhere from 12 to 51% of layers actually drop out of contact lenses, and this is disconcerting because you ultimately, yes, your patient, you fit them, they walk out the door, are they coming back for their follow-up visits? Are they wanting to buy back contact lenses? These are measures of success, and dropout in my mind is not a measure of success. So how can we not necessarily prevent this from happening, but are there steps that we can take in order to minimize the effects? I want to first take a look at aspects that contribute to the fit factors, and then the fit factors, in order to determine a good fit, what do we need to look at? We need to look at the environment factors, so the patient factors. Now, we've all been in office. Traditionally, we can apply fluorescein to the eye. We can take a look at the quality of the tear. In this example here, you can see that there is breakup occurring of the ocular lens surface. You know, is the fluorescein uniform over the cornea with each blink? Are the tears too thick? Are they of poor quality? Traditionally, yes, you can do that from behind the slit lamp. You can also use instrumentation to measure the viscosity of the tear. You can see in that upper video, you can see with each blink the time it takes for that inherent tear debris to move across the surface. In the bottom video there, we can record other components such as, you know, similar to when you drop like a drop of soap into water, you can see kind of that rainbow effect. We see that here as the patient blinks, we get an idea of the quality of their lipid layer. Here, a nice rainbow pattern is indicative of an intact lipid layer, and we know that that lipid layer is very important to maintaining the integrity of the tear itself to avoid subsequent breakup. You know, I don't know how many of you guys have had a Schirmer strip in your eye, but I certainly have, and it is not the most comfortable type of assessment. It is invasive in order to measure quality of the tear itself. Specifically, we're looking at tear volume. We can see that through instrumentation, we can get an actual caliper amount. In our bottom two images here, we can see that the generally you want at least a 0.2 millimeter value is what we want to typically consider to be a normal amount of a tear volume. In this patient, it could be a little bit less. In the bottom image there, you see above the 0.2 value. So again, it's a numeric value that you can record in your charts and get an assessment as to what the amount of tear that the patient's producing. And you can do so in a way that's not particularly inducing reflex tearing. You can also objectively look at the tear breakup. You know, you put that fluorescein on eye, and instead of counting your steamboats, let's say, for example, behind the oculars, you can more accurately and reliably repeat your tear breakup time. In this particular tear breakup pattern, you see up above in the image here, the hotter red colors show areas of breakup, whereas the cooler or the greener colors as you make your way down show areas of intact tear breakup. I'll take a look closer at the application of specifically tear breakup as I get into some of the studies we're doing over here at the university. So when you have all of these, you know, baseline findings, use the instrumentation, you get a measurement of tear breakup, you get your measurement of the tear meniscus height. You know, in any exam, you want to get the whole story. You don't want to just be able to fill in your patient's chart with certain parameters. You also want to provide the patient with a comprehensive overview so they can understand, you know, why you're doing the measurements that you're doing on their eyes. A unique feature of the keratograph I found is the Genvis dry eye report. This visual representation, you know, it can actually speak volumes. It includes listed down below, so you have values for both the right and the left eye, and listed from numbers 1 to 6. You have certain types of tests that I just mentioned, so you can include the tear meniscus height, you can include your value for tear breakup, you can include, for, let's say, you can measure the redness of the eye itself, and you know, certain conditions with dryness, you have redness of the conjunctiva appears more prominent than in others. Now, you also don't want to include just instrument findings. Nothing's better than your case history. So as thorough as, universal dry eye questionnaires, such as the, as it's mentioned here, the OSDI scales, so the Ocular Surface Disease Index scales, you can ask questions to the patient, and, fine, you're getting these objective measurements, but can you also incorporate their subjective response as well? So it helps paint the picture of what's going on for baseline findings for your patient. Now, let's say that this patient was not a contact lens wearer. They're new to your office, and you want to get the whole story as best you can. You'll also notice down there, there's a mybography area. You can incorporate the results, and also the Lipkoff or the lid parallel conjunctival folds is what that last test stands for. Specifically in certain patients that have dryness, you may see folds that start to form in the lower conjunctival area. And again, nothing's better than your own two eyes and being behind a slit lamp. But again, some of these tests and these aspects help supplement that exam and give you a bigger picture as to what's going on. So once you have your patient, say for example, in this case, you can see we have some restriction in, depending on how the patient answers. You can see this hexagon pattern here, depending on the test that you incorporate, ends up becoming compressed. And that can provide a baseline for you to go ahead and want to provide treatment for this patient. So if this patient, for example, say you applied some sort of artificial tear treatment, some sort of steroid treatment, let's say you go to a medicated like a Restasis, some sort of application for the patient then comes back at an X number of days or weeks after a follow-up, and you want to monitor their progression, you can go ahead, you can repeat the same tests, and you can see how the patient, how their patterns changed. You provide them with that treatment, they see that there's improvement, they can understand that, okay, my efforts mean something. Equally so, if there's no improvement and they haven't been compliant, because we know that obviously happens a lot too, if they're not compliant with your level of care, then that can show in their monitoring the progression that there's been no change overall. So education is a big tool here. Now, if these are the getting a big picture of the factors that affect the environment and understanding whether or not you want to treat a patient. So say you determine that this patient is a great candidate for contact lenses. You now want to go into fitting the contact lenses. Once you've established that the patient's a good candidate, you want to make sure you can maximize the coverage of the lens. You want to make sure you maximize the centration of the lens. You want to make sure that the lens is overall comfortable, and you want to improve movement. So these are, anytime we put a contact lens on, these are factors that we are looking at for a quality fit. But how can we maximize each of these categories? What can we do? So when I think of centration and coverage, a big factor for me that comes to mind is thinking about the corneal diameter. So when I look at this specific example, fitting a lens on eye, similar, you want to fit, it's kind of like you want to get the perfect fit, and to get a true representation of the shape of the ocular surface, typically, what do? We measure Ks and Rx. We take our topographies, or we use our keratometer. But we know from studies that base curve radius is not only the window into understanding the shape of the eye. Specifically, if we're going to talk about sagittal depth or height of the eye, that we need to know a little bit more information. Yes, base curve plays a role. Yes, certain corneal shape factors and eccentricity play a role, but we don't always measure that. In this very rudimentary example that I have showed up here in my pictures, we can see if I hold base curve constant, if I heard corneal eccentricity constant, and we're only adjusting the diameter, you can see that the same sagittal depth I have here corresponding to this larger diameter cannot be superimposed on on this smaller diameter eye on the left. So we do have a difference in sagittal height, and ultimately, I mean, that would make sense that, you know, a lens that would fit on this 10.5 diameter eye may not necessarily fit the same on this 11.5 diameter eye. If that's the case, you know, what does this mean clinically? We were interested in taking a look specifically at this fact. In a recent study that we completed, it was a study where we looked at fitting hybrid lenses on a cohort of 38 subjects. They had normal, healthy eyes. They were diagnostically fit with the hybrid contact lenses, and we wanted to look at characteristics such as surface wetting of the lens, overall fit, and satisfaction. Now, as part of, yes, we took baseline measurements. As part of the baseline measurement, we took tear breakup time without the lens, and then the patient had to come back at subsequent follow-up times. And each time they came back, we took tear breakup time over the hybrid lens as well. And so this was the follow-up and the protocol that we used each time the patient returned. Now, I want to look at some of the examples of tear breakup, but when we also were taking baseline measurements, what did we look at? We looked at corneal shape. We assessed what was going on. So through topography, we can see here, just based on sheer picture, you know, this is a with the rule astigmat. This looks like it's very close to lumbus astigmatism. So we can get an idea of the general anterior ocular shape through our simulated K readings. But what we can do and go one step further, and we can take calipers and we can apply it to the imaged portion of the topography, and we can assess a little bit more of the shape of the eye. So if I take, here's that same image of that eye, if I take a caliper now and I measure, you know, to truly assess corneal diameter, the cornea itself being clear, we can't really get that true amount, but we do use the visible iris diameter as our method of reference. So if I take the horizontal visible iris diameter here, we can see that we can measure an amount, in this case, 11.7 millimeters. Anatomically, we do know that the cornea is not shaped the same horizontally as it is vertically. The cornea is smaller in the vertical meridian. Therefore, when we take our diagonal measurements, we're not necessarily going to get the same value as we are for our horizontal measurements. Now, this is in point millimeter values. However, this could represent a transition into our overall fits. Clinically, to truly report on HVID, you don't always have the ability to do so. Depending on the instrument you use here, you can also do so with very simple tools you have in your office, but you can get a good idea of HVID if you're taking topography as well at the same time. It doesn't take any more additional time. As long as you apply the calipers, you can get an idea of that eye shape. Now, with this specific cohort, I know we've seen these distribution charts for time. This is not new, but I wanted to see, you know, does the distribution of our population that we use in the study kind of follow through to what's typically average? You know, average size runs anywhere from between 11.5 millimeters to 11.9, 12.0, and so I specifically just calculated the extrapolated the horizontal visible iris diameter values. We can see along the vertical axis here is the number of eyes, and then we have the values for the horizontal visible iris diameter along the x-axis. Even with 38 subjects, so specifically the 76 eyes, you can appreciate that we're still approaching this bell-shaped curve with the peak or the majority of our patients having that 11.7 range. So again, this population is falling into what we would see as a typical variation. So then I wanted to take a look at some of these eyes specifically, you know, what really happens to the differences in eye size, and is it clinically relevant? Is it something that we should be considering? Well, we know we already should be considering it, but how did it impact the cohort of the patients that we have in this particular study? So you can see here clearly this is the same magnification taken, that the image on the bottom right here, this is a smaller eye than that image over on the left, this larger eye. So what did that do to the patients that were wearing their hybrid lenses? So here is two examples that I've pulled out. There's a small eye. This is closer to that that smaller than average eye size. We can see that the lens looks, it's a different fit. If I actually outline where the lens is sitting, it's not hard to see that the lens is sitting differently on the image on the left versus the image on the right. The eye on the right is over that 12 millimeter range, so that's a larger than average type eye is what we're looking at. So again, this tells us, or tells me specifically, that there is some aspect of eye shape that's playing a role here. So if I'm behind my oculars now, what do I see? So here's two separate examples, hybrid lenses on eye. There's a little bit of an artifact here. You can see that there's almost a shadow created by the diffuse beam of the GP portion of the contact lens, and it looks like the image on the right is actually well centered around the pupil, whereas the image on the left is a little superiorly decentered. If I actually point out where the pupil is, and then we go ahead and outline where that GP is, you can see that the lens on the left-hand side is actually centered up pretty well, whereas the one on the right is displaced inferiorly and temporally. So strictly based on eye size, specifically cornea diameter, which can be easily evaluated in office, and sometimes is an overlooked parameter, it does play a role in the overall, we know it plays a role in the overall sagittal depth of the eye, and specifically that gives us an idea of the overall ocular shape. What does this translate to? So clinically we'll see this. What does this mean now for our patient? In this particular example, you can see that I wanted to go ahead and now take a topography over top. The lens image that we had on the right from before that was centered up, you can see the topography confirms that it is truly centered. For the lens on the right that was decentered inferior temporal, you can see that the topography over top is showing this and depicting it. As well, there is a diopter, about a diopter of induced corneal sill. This is something that is picked up on the patient. We are getting, in this particular example, I was getting residual sill come through. So this helps explain where that residual sill came from, particularly with respect to the decentration. Now, whether or not this is of, you know, a correctable amount, in this case, no, it was something that a patient reports that the vision is just not as clear at a certain amount of time, and so that particularly can affect how the patient feels about the satisfaction of these lenses. Another hot topic where I think we are going to see more of this, and where I want to actually apply this concept of looking at the decentered lenses and the amount of residual sill. We know right now, for those of you out there that fit scleral lenses, that scleral lenses tend to decenter specifically on the eye because of the variety in scleral shape that we hear a lot about. When we take topographies over top, that can give us an idea about, you know, potential over refractions or residual sill that we're getting with patients. So that's an application that I know that we're going to be looking forward to in our future studies here at the VRI. The VRI's role in understanding how decentered lenses or centration in general can be improved is definitely a goal on our agenda. Equally so, you know, if a lens decenters, what goes hand in hand with understanding what's the impact of that decentration is the pupil size. If that lens is decentered and the pupil is large, we know that that lens is not going to perform that well for the patient. They may complain of aberrations, of glare, of halos. By measuring pupil size through instrumentation, for example, here, you can record an adequate, an accurate value too of what the patient's pupil size is. Not only will it impact, again, the fitting of contact lenses, specifically in this particular case for hybrid lenses, and like I said, going forward with scleral lenses, but multifocal optics. We know that in order for multifocal optics to work, they need to really line up with the patient's line of sight and well centered on eye in order for them to appreciate clear vision. We already know that that is something that we battle, and understanding and recording the pupil can help us pupil size can help us understand potentially down the road why our patients aren't necessarily getting that crisp vision that we expect them to. It just helps from an education standpoint for the particular patient. Now I want to switch gears a little bit. Yes, okay, you have a great story about your baseline parameters. You understand the diameter of the eye. You can get a feel for what the environment is. You can get an idea for how pupil interactions may occur. But now it comes time to fitting you want to choose between lens materials. How do you know if certain materials could be better suited to the eye that you're working at versus others? Again, that was a question we were interested in asking ourselves here at the VRI. Do different contact lens materials perform different when it comes to wetting? We hear with new materials coming out that it's all about increasing patient comfort and tear contact time as the patient wears their lenses. So what we did is we took the same example, same patient for all three of these scans, and we did a tear breakup time. We did that without the lens on, so baseline finding. We then took a measurement over top a silicone hydrogel contact lens. With typically it's easy for you to be behind an ocular, and you can apply fluorescein to a GP lens on eye, and you can see how the tear coats over the surface of that contact lens. But you can't necessarily do that over top the soft contact lens. You'll potentially stain that patient's contact lens, and they have to go home with it. With the tear breakup time tool for the keratograph, we can see here that the quality of tear that passes over the contact lens surface, specifically over the soft contact lens, is not that, the integrity of it is not that great in this case. We can apply the same methodology over a scleral contact lens, and you can see that the tear breakup time in this case is much longer, and in fact the integrity of the tear over top the contact lens works well. Now for this patient, does that mean that scleral lenses are the go-to choice? Perhaps, or it means nothing. It just helps us understand better if a patient comes in and they're symptomatic, how can we best provide them with a contact lens that can improve their quality of success over time. If a patient says they have dry eyes, maybe let's take it to mean that they truly have dry eyes, and there could be something that is potentially out there that could make it better. We hear it so often that we can get bogged down by that fact, and we may just, tell them to decrease wear time or tell them to make adjustments with artificial tears. And sometimes if we dig a little deeper, we can develop a bit more of a story to understand what's going on with these patients. So what we did was the same concept I applied to the hybrid lens study that I talked about. So when those patients came in, they had a baseline visit where we took a tear breakup time without any contact lens on. They were disfigured